Our next lecturer is Jim McGuire. Jim runs the wound clinic at Temple University College of Podiatric Medicine, formerly known as PCPM. And I am. I feel old sometimes. Jim is going to be speaking. He's one of the last words on foot care, diabetic wound care, and offloading of the diabetic patient, both whether it's appliance offloading or surgical offloading. Jim will be speaking on offloading of the diabetic patient and using evidence-based medicine and the new diabetic international guidelines for that. I guess it's new old.
2015.
Yeah. Okay. So
that
let's.
Could be old. Who knows?
Anyway, here's Jim.
Thank you very much. Okay, I have a couple of financial relationships. One is Hollister, BSN Medical, who's one of the sponsors for this morning for me. Bonapeda, who's the other sponsor for today. Smith Nephew, Osiris, and MTF Wound Care. So let's start right into this international working group. It's a group of clinicians, world clinicians that are experts in diabetes, who have put together a guideline, and they get together every 4 years, and they go over all the new stuff that's out there and all the new research and kind of rate the research and develop a guideline for managing the diabetic foot using this document. And there's some heavy hitters in here. It's Armstrong and and Buss and Van Dersen. There's some really well educated and researched diabetic researchers on here. And they come up with this guideline. You can go online and just put in International Working Group, and you'll come up with a number of guidelines, not just offloading. This just happens to be the offloading part. There's also on management of diabetes and everything else in there. And in that guideline, they came up with these are some of the high points on this. And I think it's wise to take these guidelines and then use them to manage your practice. Like, how are you going to take care of your diabetics so that you are using best practice, you are using outcomes-based medicine when you apply offloading to the diabetic foot. So the first one is to heal neuropathic plantar foot ulcers without ischemia or uncontrolled infection. These are patients that just have a wound and you're trying to manage this wound. They tell you to use a non-removable knee-high device. Now that's the, I just put in there TCC, instant total contact cast, and there are several other non-removables we'll talk about, with an appropriate foot device interface. And it's interesting that they put that in there, is that what they're trying to tell you is you don't just use a non-removable flat bottom device, that you want to have something that contours, that takes some of the weight off different parts of the foot, built into even the non-removable device. The second one is when a non-removable knee-high device is contraindicated or not tolerated. So this was actually a bunch of realists in the sense that they know that there are patients that are going to tell you, no, I'm not going to do that, or I won't wear that, or I can't wear that, or they're physically incapable of walking around in a cast or managing, kind of living in it with a cast on. So consider a removable knee-high walker first with an appropriate foot interface, and we'll see why that's true. And then when the patient can be expected to be adherent, I put that in red because if I don't know if you guys, if you really treat diabetics, you never expect them to be adherent. If you do, you're crazy, because they will not do what you say, and they try to get out of these little, and the evidence for that is even weaker or moderate. When a knee-high device is contraindicated and cannot be tolerated by the patient, consider offloading with a 4-foot offloading shoe, cast shoe, or custom-made temporary shoe. And these should also have that doesn't have in there that should have a contoured interface. But in all reality, you can't really take just a flat shoe and do this, so it should have a contoured interface, just like the other two recommendations. And then there's a couple other really long ones, but I just want to get out of the bottom. And it just says on there, there's no particular preference for a TCC or a prefabricated non-removable knee-high device, which I thought was a very interesting statement to make, given all the evidence that's out there for total contact cast, to heal plantar foot ulcers. The evidence is not monumental. It's good, but it's not super strong. as long as an appropriate foot device interface is maintained. As long as appropriate interface is maintained. We conclude that the quality of evidence is high, that you don't have to use a TCC, but we'll talk about why that is important in a minute. Then it says, do not prescribe shoes for a plantar foot ulcer. Do not let your plantar foot ulcers remain in footwear for managing them. Consider using shoe modifications, temporary footwear, toe spaces, or orthoses to offload and heal a non-plantar foot ulcer. So they will have you use a shoe modification for a dorsal wound, but not for plantar foot ulcers, which require offloading. If other forms of biomechanical relief are not available, consider using felted foam, which they put in, I think, just to give homage to the few studies out there that show felted foam is actually a fairly efficient way of removing pressure from a small, partial thick, or just sort of not exceptionally deep plantar ulcers. So this is just looking at costs of diabetic amputations, and why we're getting into this is that diabetic limb complications are associated with amputations cost more than breast cancer, colorectal cancer, lung cancer, prostate cancer, or leukemia management in the United States. There are a number of risk factors that come together when you're looking at offloading a diabetic foot. First is diabetes, and then peripheral neuropathy, which leads to foot ulceration and may lead to limb loss, particularly when it's coupled with peripheral arterial disease, and then critical limb ischemia, obviously, when that gets really bad. The etiology of a neuropathic ulcer are many, and it's not just neuropathy, although that's the major one. Neuropathy and foot deformity are the other two major ones. And then it's kind of lifestyle, footwear, repetitive stress. You can add in all those other mechanical stresses that cause the foot to break down. And then they have that sweet spot, or that what's called a sufficient cause. These are all component causes. And when they all come together in the right, perfect storm, you end up with an ulcer or the sufficient cause. The 2006 guidelines included offloading as one of the major components of trying to heal a diabetic foot ulcer. And we came up with this a few years ago at Temple, which is to develop a transitional offloading approach to managing the diabetic foot ulcer. You don't use one offloading device and then pop them right back in their initial footwear. You start with a non-removable device, progressing them to something removable, preferably with a fixed ankle as per the guidelines, then go to a free ankle removable device while you're waiting for their final footwear. The worst thing you can do with a diabetic is take them out of a total contact cast with a healed ulcer and put them back in a depth shoe, which is either brand new and recently modified, or their old one, which if you were wearing a shoe that caused an ulcer, you probably shouldn't go back to that exact shoe again. It wouldn't be wise. Total contact cast, this is a 1987 statement by Paul Brand, that it was currently the gold standard for off-weighting the plantar insate foot. People are still saying that. It's the gold standard. And we're going to talk about what a gold standard is and why I worry about that sometimes, although it certainly is a gold standard for outcome of therapy. To heal neuropathic plantar foot ulcer without ischemia or uncontrolled infection in a patient with diabetes, a non-removable, this is the guideline, knee-high device, which a total contact cast falls into, or the instant, with an appropriate foot device interface, which is you took some time to contour the plantar surface. Well, how does a TCC offload? Is it really that contoured plantar surface? And the majority of offloading in a TCC occurs with the leg cone of the cast. 30 to 40%, based on a couple of studies that are out there, of the weight is actually pulled off the foot by the cast itself on the leg, which is why when you have fluctuating edema and lots of swelling in the leg, or a conical shaped leg, or a cylindrical shaped leg with no real contour to it, that the cast has a hard time working well. It just becomes an immobilizer and not an offloader. The other thing is that weight is taken off the forefoot and shifted back. So total contact casts tend not to be really great for heel wounds, although there's a statement by Armstrong that although the total contact cast is not particularly good at removing pressure from the heel, it is the preferred offloading method for heel ulcers because it does a decent job at offloading the heel. But it does shift most of the weight off the ball back to the heel and midfoot, and then most of the weight again is borne by the leg. And we did a study at Temple where we took two different, it's called the boot study, where we looked at two different designs of total contact casts. One had a really, the traditional one, which is a really tight foot, a really tight ankle, and a cylindrical cast. And the other one had a really tight cylindrical cast on the leg, and then the foot was just padded all over the place. And was there any difference really in the offloading between those two types of cast? And there wasn't. So what we concluded was it's really this leg section that makes the difference. That's the part of the cast that really needs to work. So if you look at a bunch of TCC studies, this is why this is called the gold standard for offloading, is that the average healing time is about 40 days. The percent healed is 89 to 90%. And these were 9 good studies by Sinecor and Mueller. These are big people, Lavery, Armstrong, that have done these studies in offloading the diabetic foot. And this comes from Fife's article, Why Is It So Hard to Do the Right Thing? We'll go back to that in a minute. This is the days to healing. If you look at a total contact versus an instant total contact cast, which is the non-removable walker, they're very similar in the days to healing and the amount of time it takes to heal. The minute you make it removable, you shoot from 90 to the 50s. So as soon as they're allowed to take it off, Armstrong's study says they wear it how much of the day? Anybody remember? 28. So you wear it, if you have a removable device, you wear it 28% of the time, on average. And very, very compliant patients, they singled out a group called super compliance. The very compliant patients only wear it 60% of the time. It's because they take it off, they never wear it at night when they go to the bathroom. They run down to the kitchen just to get something. Oh, I'm only going to get up to do the TV. Oh, the doorbell. I got to get to the doorbell. So just this one time, I got to go to the store. I just won't wear it this one time. And then those one times add up. So I think this is very interesting. Those of you, you'll see a case later, which I think is very interesting in cost. And this is looking at Amplegraph, Dermagraph, and Regranix, and looking at their pivotal studies compared to the total contact cast. The days to healing versus percent healed in 12 weeks. And if you look at those, there's really no comparison between casting and immobilization and appropriate offloading and these expensive grafts. And the key to graft success is good offloading. If you couple the two together, you really heal people very quickly. Okay, indications for this. Plantar ulcers, Wagner 1 and 2. University of Texas Health Science Center, A and 1, 2, 3. You don't do it on infected people. You don't do it on people with severe ischemia. And it's great for Charcot and post-reconstructive surgery. So everybody ought to use this. So they did a study. This is Wu and Jensen, 895 respondents who treat diabetic foot ulcers, and they total contact casts were used by what percent of centers that they evaluated? How many people here use total contact casting on a regular basis all the time for offloading the foot? Okay? That's about right. Percent of response was 1.7%. Sorry, I'm coming down off a cold.
Like some water?
Which I probably got from taking things in and out of the garage for Christmas. So this is another study. This was Carolyn Fife looking at the U.S. registry, the wound registry, and connecting diabetic foot ulcers with the code for total contact casting to see what percentage of centers across the United States were billing total contact casts on a regular basis. So this is a national one, looking at the registry, and this was what percent? 6. Only 6% used the gold standard for offloading the diabetic foot. So we've come up with a bunch of conclusions about this, and that it's really hard to call something a gold standard if nobody uses it. It's nice, but nobody's in it. So it's the gold standard that the gold no one can afford anymore. It's the economy. This was looking at podiatrists. So podiatrists we're so much better. We're only 11%. We are better, and we recognize the need for offloading, and more of us do use that, but only 11%. Now, there are contraindications to using a total contact cast. One is any kind of infection, fever, nodes, a deep infection that you don't know where it goes, lots of drainage, so they're going to just soak that cast and be in it for several days, an active dermatitis or some sort of skin condition, edema that's going up and down. I'm beginning to list the majority of diabetic patients that you see every now and then. My favorite one is claustrophobia, which is that they try to get out, or no non-compliance. Like, what's, stories, like what's the worst story you had with some guy trying to take a total contact cast off? Hacksawing the top of their ankle, that's one. The other one was taking wire cutters and trying to chip one off outside in the cold because his wife wouldn't let him do it in the house. So he caught pneumonia. It's like these stories, they'll do anything to get it off. But if you have no non-compliance down as a contraindication, every one of us is going out of our way to write down any instance of non-compliance in our record for legal purposes. So almost everybody will have that contraindication. Arterial insufficiency below 0.8, and any kind of the gangrene or necrosis on the skin. But what about complications? We always worry about total contact cast complications. I don't want to put them on because people, I don't want to put them on because, people get ulcers when they wear them, and they're going to get a problem from me doing something that is going to be bad. So I don't want to do it. Well, that actually is very, very few patients actually have significant complications from wearing total contact casts. They looked at a series of total contact cast applications, a long series where they just did every single patient that got a total contact cast, what percentage of patients had to have it removed or adjusted because it was causing a problem. And it was 93% of those complications that they got. First of all, the complication rate was really not that high in patients that you had already not identified as high risk. So in a patient that's not high risk because of the conditions that they have, the incidence is like 4 or 5% or less. And those complications, 93% of the complications that they saw, even in the high risk group, did not require that you stop total contact casting, only that you modify the therapy, that you treat the complication, change the casting technique a little bit, and you could get it back on. So why doesn't everybody use it? These were the things that people said are reasons why I don't use it. One, patients won't accept it, or I don't know how to do it, so I don't want to do it. Time needed to apply. I don't have time to do that in my office. Actually, if you practice doing a total contact cast, you can put one on in about 10 minutes, and you can teach staff to do this. If you trust a staff person who's got good hands, you can teach someone also to do the technical application of a cast. Cost of materials, it's not that expensive, and you should be able to actually make money on total contact casts versus lose money on total contact casts. Reimbursement issues, and that probably is a case in some parts of the country. We haven't had that problem in Philly, and I have the worst insurance in the world. I don't know about New York, but up in northern New Jersey, but Philly's horrible. And I sit in the worst catchment basin. Like Temple's motto is, we treat the indigent. And we're proud of it, and they are. But that also means they're always in a red on their budgets, and they never make any money. Customizing parts was one. Staffing, ordering supplies, that they have to do that. The advantage to some of the kits that are out there today, you'll see a total contact kit out there in the exhibit hall. It's like the kits make it so easy. Just open the box and put the cast on. There's everything in it that you need. And then clinician coverage, whether you have a clinician that knows how to do it or somebody that can help you. How do you improve patient adherence? Increase their knowledge of the disease. Why am I doing this cast? Because it will help you. Improve their foot care knowledge, like how to take care of this problem. Review their compliance history. Like if they've had a problem with casting, you don't want to put a total contact cast on a person that already has a couple of failures. Try something else. They're just a high-risk patient. Reduce the complexity of treatment or therapy to increase use, so it's not complicated. We're going to take care of this. It's not that hard for you. Address patient fears, solicit family support because they'll need it, and then emphasize successes. Like every time you put one of these on, you will see a significant reduction in size of the wound. It really responds to total contact casting. How do you get physicians to accept it more? Emphasize outcome-based practice, which is it is considered gold standard. Admit your patient's real compliance history, which is they're really not very compliant. Reduce the complexity of treatment or therapy to increase use. Address your concerns, like talk about them, like why don't you use this? Educate and train your staff, and then use commercially made kits to improve the use of application so that you don't have to like hunt around for supplies. This is why it's a gold standard. It's easy, and if you use these kits, why it's become easier in the office to do this. We have used every kit on the market. The top kit is one that produces a cast that's pretty similar to the standard Paul brand type total contact cast. The one on the bottom is one that has a sleeve. You just slide it on the leg, and they give you a walker to use with it. And then the one to the right is one that's sort of a hybrid. It's in between the two of those. There are various differences between the kits. Some of them are easy, some of them are not. Some of them are intuitive, some of them are not. Some of them are flexible and don't really control the leg, and you either have to reinforce them or not use them. And you have to keep that in mind when you're looking at all these different kits. So what do we use? Shoe modifications, 42% of the time, were the most common form of pressure mitigation. 15% of the centers used a removable cast walker. 2.6% reported application of other things. And then 12% of the centers reported complete non-weight-bearing strategies, which that really goes over well. Here, use crutches and don't step on it. You're doomed to die. No consensus. 58% of the centers in a 520 center evaluation did not consider TCC the gold standard. Now, it depends on what your definition of a gold standard is. If it's, what is the treatment gold standard? Based on research, the TCC wins hands down. There is nothing better. But what is the gold standard based on usage? Like, what is the reasonably available and used device that gives you the very best results? And that's the non-removable cast walker or a cast walker. So using either one of those, you're going to be delivering excellent care to your patient. The third one is that if you can't get into one of those things, that's some sort of offloading insole in a surgical shoe so that you have a contoured insert. And even if you use that in your total contact cast in your removable cast walkers, it's even better. So 45% of the centers nationwide didn't use TCs at all. At all. So if the offloading device used by most practitioners is a shoe or shoe-based, what you might call the shoe, if you're using a shoe, you are the reverse gold standard. It means anything would be better than that. So if you're using some kind of shoe alone, by itself, a non-contoured, non-rocker, just a shoe, you're like way below the standard. You become, anything better than you is better than that. So this was, if a therapy device is used by less than 6% of clinicians, yet has superior data when compared to most other alternatives, the best it could claim is preferred status, but not gold standard. It has to be reserved for something that's used on a regular basis by most clinicians. So we can, what really that guideline is saying is use a non-removable device, an NRD, a NERD. Put a NERD on and you'll be doing gold standard care. Don't forget ambulatory aids, they do help a lot. Even a cane changes people's gait a little bit. So some alternatives is the irremovable cast walker. This is the two different types that we use. I like the zip tie. You just put the cast walker on, put a zip tie on, and tell them don't cut it off. If they're devious enough to go to the hardware store, get the same zip tie, take it off, put it back on again, then they deserve whatever they get, and I'm not responsible for the fact that they fooled around with this. But at least they have it. If they try to cut that one off on the top, if you're taking a scissor and you're trying to cut off Coban and you can't peel it off, they'll cut a strap. If they cut a strap, the thing doesn't work very well. So I don't want them to ruin the thing. I want them to just take it off and admit to me they took it off. So we try to make it easy. This is the Raider football dressing, and if you look at there, the component parts of it, it's a big fluffy foot. And then you put that into a surgical shoe or a removable walker. That works fairly well. We've done that in a lot of patients that just won't tolerate a cast, but they seem to like bandages. So we just put a non-removable bandage on. And we always use a sort of a felted foam technique style inside the bandage. So we add a little extra padding. And that's the felted foam dressing. And there was the Burke and Pavish study, which showed that it compares well to total contact cast in their hands in that one study. That's why the evidence is weak. Removable walkers have a fixed ankle and a rocker sole, which makes it work better. It reduces anterior-posterior shear during gait and has a low profile, so it doesn't like jack your hip up in the air. One of the problems with the standard TCC is that they walk on that peg and they're way up high, and they do get a lot of hip problems and postural problems associated with wearing the classic TCC. So this is the 28% from Armstrong. This is a limb load offloading brace. This uses Velcro to hold the leg up off the bottom of the brace. Velcro with a 250-pound diabetic doesn't hold very long. So they're usually not any better than a regular walker. If you go to the trouble to have a patellar tendon-bearing top put on, they do get a little better contact, a little better offloading with this. But if their limb edema goes down, which usually that'll happen, they slide down in the device. And you can't ignore the foot interface with any of these things. Like, you need something in your surgical shoe, something in your walker, something in your device that's going to contour that base to the foot or selectively offload areas of ulceration or high pressure. And there's a lot of things out to do that. Or you can even have a torch boot made. Torch boot is a custom molded shoe that goes all the way up the leg. The reason this works a little better is it's laced. So as their edema goes down, they can tighten it up. But it's also $2,500. They're very expensive. This is an Arizona brace, articulated Arizona. That's just another possibility. Crow boots are ridiculous first line for diabetic foot. They're way too expensive. They really don't effectively offload. It's buying a $2,500 cast walker. And you should just use a regular cast walker for that. So here's this transitional idea that we come out of this, we go into a non-removable device, get the wound healed. There's a time period in there when they transition into a removable device, and you observe to see what's happening. And then you put them into maybe a free ankle device and order their shoe. And try to stay ahead of things so the shoe arrives when it's time for the patient to get into it. So this is looking at the guidelines when a knee-high device is contraindicated and can't be tolerated. The forefoot offloading shoe, cast shoe, or custom temporary shoe should be used with a contoured insole. Current shoes that are out there on the market, there's everything from the Darko rocker sole or some of the ones that have rocker soles, which I prefer. The wedge shoe is, if you want your patients to fall a lot, give them a wedge shoe. Or if you want them to have Achilles problems, because every diabetic has glycosylated Achilles tendons, they're all tight. They all have equinus, so when you put them in a toe-up shoe, like that wedge shoe, they're basically standing on their forefoot all day. You'll increase forefoot pressures or significantly alter their gait. You ever watch them where they bend their knee and they walk, they touch the front to the floor? It's great. And a half shoe, I tried a half shoe once. I got the ulcer healed because the patient fell and broke their hip. And the ulcer healed beautifully because they were completely non-weight bearing. Luckily, I didn't get sued. All right. Patient said, it's my fault. It's my fault. I always write that down. Extra depth shoes to heal diabetic ulcers, never intended to treat wounds. They are your final footwear. And they should be used after a while. Like, how long does it take after the skin heals or closes? How long is it before that skin has any structural stability at all? It's 3, 4, 5 weeks. Like, an incision takes at least 21 days or longer, particularly plantar incisions, to really knit together so that you can feel secure that the stitches can be removed and nothing's going to happen. Well, you can imagine a chronic wound that just has like a micron of epithelial cells across the surface. You can't turn it loose to walk in any device. So it has to be put into something that's going to offload it selectively. And you want to give them something that is like a shoe, but not their final footwear. Commercial wound care shoes are out there. This is one of them that's out there. They sometimes come in pairs, and they have other reasons for that those are available. They're also a little on the expensive side. You can use the modified surgical shoe technique, or you do something like a direct mold or heat mold, but you can also use a commercial product that's one of those pixelated insoles that's out there, and there's a great company here that has one of those for you to look at today that we've used at the clinic and happen to like a great deal. because it has a lot of features that make it sort of a little better than some of the other ones out there. But a surgical shoe, if you pick one with a rocker base. It's not flat. They're not like plopping around. They don't have that sharp plantar flexion that they get. They have a little roller heel. They have a rocker sole. And the insole that you want to go in there actually fits in there. This type of device, you have to take the patient, mold them, grind them. There's a lot of fussiness with this. And you'd like something like this, which is one of those pixelated devices. There's segmented insoles and heat molded. We've used segmented a little more lately. There's the ones where you take the pixels out on the top and ones where you take the pixels out on the bottom. We prefer one where you remove the pixels from underneath because you don't have edge effect. And those loose pixels, they fall all over the place inside the boots and everything. And we always have to put a top layer on them anyway. Once we pull them out, we put an 1/8 inch plastisone on it and glue it down. But that's extra work too, so you want to try not to do that. Devices where you pull the segments out from underneath, they have better structural integrity because it's all tight and held together, and there's no edge effect. So that little edge effect that you get from pixels right against the skin, you lose that when you have a good interface that just kind of creates a nice soft dell with no edge effect. You'll see a case later where we use this exact device, but they're made to fit nicely into the surgical shoes of different sizes. You can trim them by hand, or they also come sized in some of the companies. And it's nice if they're sized to fit the shoe that you have because they pop right in, but it's also easy to take a scissor and cut the front end off so it fits directly in there, and then you pull the pixels out. This is one patient that was, if you know this guy, this is the definition of somebody who's a perfect diabetic for a podiatry standpoint. One is he's always in the office, and two, he never does anything you tell him. So he's completely non-compliant. He trashed total contact casts. He had all kinds of problems with everything. He would only wear a shoe-based system. So I finally gave up and I put him in this pixelated insole and just pulled the plugs out from under the first mat head. And the thing is, he was willing to wear that all the time. He wore it like a slipper. He wore it all around the house. He didn't give me any grief about it, and it healed in 5 weeks. That's a decent case. And then the other guy had that's that one where we pulled the pixels out onto the hallux. He had really keratoderma, really thick callus, the kind that separates into multiple layers, and he was always getting heavy callus there. So he debrided. I don't have the before picture in that one, but that's the after picture where it did heal. But he's got so much callus, he needs regular debridement, and he needs to be in a special offloading shoe. But this was the transitional shoe that helped us get his final footwear onto him. This is a Harry Penny slide, University of Pittsburgh. Wound presented like this, pre-debridement. 55 years old, diabetes. If you just close your eyes and just set a history of a diabetic, they're all the same. 50 to 60, neuropathic, kidney disease, sugars not or poorly controlled, microvascular disease, dry skin, scaling. They all kind of look the same. Nail problems. This guy had Charcot the first cuneiform joint. He'd had a bunch of applications. Now, this is interesting because he'd had 4 applications of Biovance, amniotic membrane. Now, add that cost up. Then he was placed in a surgical shoe with a pixelated insole with a proper cutout for the ulcer, which is, what does that cost? Figure your market. And wound closed in 4 weeks. And that's in there mainly to show you that you can't use these fancy chronic grafts without significant offloading. You need to offload the foot. This is an easy ulcer to heal, but it's also a difficult one to heal if they will not be compliant or follow through with your instructions. And it's not going to help you too, and this is just looking at the graft, wound area volume. Diabetic ulcer, gas gangrene, osteomyelitis, had surgery. They did an IND on this patient, opened it up, and eventually they got around to using an insole treatment because most of the wound was dorsal, but it had a big plantar ulcer associated with it. So they treated this with dressings and one of these pixelated insoles, and it worked very well in this case to manage that. It's also one where they had multiple dressing changes, lots of drainage, something that maybe a TCC is not a great idea. This is a puncture wound in a 60-year-old, very similar, plantar wound, got infected, had an IND performed. They basically managed this with a pixelated insole, decreased activity, an offloading ambulatory aid, and it went on to healing. So that's the basic talk. Anybody have questions on anything? No, it's too Sunday morning. No questions. All right. Thank you very much. I appreciate your attention.